Lovely. Thank you very much for the opportunity to speak to you today. I'm going to talk about chronic pulmonary aspergillosis, which formally is not invasive, but it certainly kills patients and therefore needs addressing, I think, in a formal way. In this relatively short period of time, I'm just going to cover a few of the topics that are pertinent in this area. So the first thing to recognize is there are different clinical phenotypes of this problem. The commonest is in the middle of the slide, chronic cavitary pulmonary aspergillosis. And when this progresses, which it does when it's not diagnosed in many patients, you get fibrosis of the lung, chronic fibrosing pulmonary aspergillosis, or destroyed lung. There are also patients with Aspergillus nodules, and this mimics lung cancer. A study in Denmark suggested that about 1.5% of all patients who were thought to have lung cancer based on nodules actually had aspergillosis. So it's an uncommon differential diagnosis, but it's obviously important because these patients don't need chemotherapy and big resections. Some patients have very few symptoms and unilateral disease. They have a simple or single aspergilloma, and this is basically a surgical disease, and it's helpful to recognize that and distinguish that from the chronic cavitary cases. And then the other group are patients who are somewhat immunocompromised, typically patients with low-dose steroids or methotrexate, and they get a subacute invasive disease, which typically presents over 4, 6, 8 weeks. And those patients should be regarded as having invasive disease and treated as such. So the challenge across the world is that the chest x-rays look pretty similar between patients with TB and patients with chronic pulmonary aspergillosis. And of course, CPA follows TB in some cases, and so it mimics and follows. So it is a confusing situation. And this is one of the reasons why the diagnosis is tricky. So there are basically 3 elements to diagnosis. There is a chest x-ray that is suggestive of CPA. If you have a normal chest x-ray, that excludes the diagnosis of CPA. You have compatible symptoms, which typically have been present for 3 months or longer, sometimes for years. And I'll talk about what those symptoms are. And then you have, in most patients, a raised Aspergillus IgG. So this was the old precipitins assay introduced in the early 1960s, and now with ELISA and other formats. And the combination of those 3 things leads you to a diagnosis of CPA. So some patients have very few symptoms. Sometimes the chest x-ray is very typical, and some patients have negative Aspergillus IgG. So this is not the totality of it, but it is the main issue. So late last year, we published a paper revising the burden of this problem in India. And as you recognize, amongst patients with TB across the world, about 45% are clinically diagnosed. And many of those probably don't have TB. It's difficult to be absolutely sure, of course. And what we do know now is that somewhere around 20-ish% of patients who are smear negative or gene expert negative for TB actually have CPA. So when we looked at this burden, and I'm not going to show you the results of that, but more how we approached it, we looked at patients who, the proportion of patients who were newly presenting, who looked like they might have TB, who actually are misdiagnosed as having TB. We looked at the proportion of patients who have both CPA and TB, and that's sort of around 3% or 5%, that sort of range. Then there are patients who develop CPA towards the end of their treatment for TB or immediately thereafter in the treatment, but within that 12-month window. And then we looked at patients who died from those infections. And then there are patients who recover from their TB and are cured, usually left with, and if they're left with a cavity, then they may get CPA as a later complication. So there's different settings in which this occurs. And one of the key settings is this post-TB patients with coming back to clinic. So in Vietnam, 52% of the patients coming back with symptoms had CPA, and in Delhi, 57%. So this group of patients coming back with possible recurrent TB, it's very important to look for CPA. There are lots of different underlying diseases associated with CPA. So classical TB in our series was only 17%, but across the world it's much higher than that. Atypical or NTM infection is a very common coexistent diagnosis, but also confusing diagnosis. And then you have patients with ABPA, COPD, pneumothorax, patients who've recovered from lung cancer, had surgery. Many of those will have COPD. Pneumonia seems to be an underlying risk group in some patients. Sarcoidosis, rheumatoid arthritis, and ankylosing spondylitis. And then a group of patients who do not have any underlying disease, apparently. In our series, it was quite low, but in other series, it's around 15%. And we've been doing a lot of work on the genetics of this entity, and there are clearly some genetic defects associated with CPA. So it may be that these patients have a particularly strong predisposition to the infection. So here is an example of a young woman originally from Pakistan who presented with hemoptysis and had a single or simple aspergilloma. She was in her 20s. She was about to get married, and one of the problems with patients who need antifungals is that the azole antifungals can't be given during pregnancy. So it was appropriate in this woman to resect her aspergilloma, and she's done very well since that time. And patients with these unilateral disease that can be resected do well. This is a good outcome for them. And at the other end of the spectrum, you have chronic fibrosing pulmonary aspergillosis, as in this woman who eventually died of her disease. And you can see on the chest x-ray, large aspergilloma in the apex, major complete fibrosis of her left lung. And then we grew multiple different colonies from her, and the aspergilloma looked like this. It was seated in the cavity there. And this phenotypic variation and slow-growing strains are very typical of patients with aspergilloma, and they can often be resistant and quite difficult to test for antifungal resistance as well. And some work that Paul Boyer in my group, in our group, has been looking at, looks like there are some very distinctive genetic variants amongst the isolates with CPA. So this scan illustrates the challenge from a radiological differential diagnosis perspective. So you have a large clean wall cavity in the apex of the left lung on the right side. This is a previous NTM infection which has been cured. You have emphysematous bully from a patient who smoked a lot on both sides. And then you have a cavity with an irregular interior wall and pleural thickening, and this is all fungal growth within that cavity. And so this is not an aspergilloma, this is pre-aspergilloma, and it's much better to try and make the diagnosis at this earlier stage than wait for an aspergilloma to appear. So if you have chronic cavitary pulmonary aspergillosis and an aspergilloma, your outcome is worse. So the symptoms: cough, it's usually productive, shortness of breath, weight loss, tiredness, coughing up blood, a bit of chest ache and discomfort. So the only thing that's really distinctive about this compared with TB and some other chest diseases is that the hemoptysis is often quite marked in patients with CPA. But otherwise, this is not very distinctively different from patients with COPD or some patients with asthma and ABPA and patients with lung cancer early on and so on. You sometimes get fever. Sometimes the coughing is so severe you get rib fractures, so chest pain, and they certainly do get bacterial infections as well. So there's often some coexistent bronchiectasis and distortion of the pulmonary architecture. So bacteria are often grown and need to be treated in many of these patients. And some patients have very few symptoms. CPA is a very quiet condition. It's completely unlike pneumococcal pneumonia. And many of the patients have very few symptoms, and it trundles along slowly, gradually getting worse over many months and years. And that's why some of the patients present quite late. So here's an example of a patient originally from India living in the UK. He actually had documented TB twice and was fully treated. He then developed new shadowing in the lungs. You can see his right upper zone is pretty affected, and he's got what looks like a cavity there. Very few symptoms, just a bit of cough. He was working 60 hours a week as a builder. He had a strongly positive Aspergillus IgG here and normal inflammatory markers. And so this is a fairly typical type of presentation of patients with CPA. The original referring physicians weren't quite clear what was wrong with him, so they did a CT scan, which was entirely appropriate. And you've got this marked pleural thickening. You've got fat ingress at about 7 o'clock, which indicates inflammation in the lung. And maybe some cavities. It's not very obviously cavitary, but there are probably cavities there. And because they were still unsure, they then did a PET scan, which is not normally done in these patients. And you can see the remarkable amount of pleural inflammation that you've got in this patient. The orange and yellow illustrate that. And you've also probably got 3 aspergillomas. In the top slice at about 5 o'clock, that gray area, probably an aspergilloma. At about the middle slice, a much smaller one, or maybe it's the same one inferiorly. And then at about 11 o'clock on the bottom slice, a very small aspergilloma. And you can't see those on the CT scan. So I'm not recommending you do PET scans. I'm showing you this to illustrate how much inflammation there is with a patient who's got very few symptoms and normal inflammatory markers. So this is a patient with sarcoidosis with actually a single large cavity and a bit of pleural thickening around it, coughing up a lot of blood. Almost died of hemoptysis on one occasion, really serious hemoptysis. And what I'm showing you this to you is to illustrate the chest X-ray abnormalities of these patients with pleural thickening, cavitation, and pericavitary infiltrates. And the pleural thickening is not very marked in this patient, but it's there. But these little inferior cavities here, and which are what you might call pericavitary infiltrates. That's how we would define them. So in Kampala in 2018, Gaffey held a meeting to examine which diagnostics are required for advanced HIV disease and other serious fungal infections. And we, immediately after that meeting, we submitted information to the WHO panel looking at which diagnostics should be on the new essential diagnostic list. And that included cryptococcal antigen, blood culture, direct microscopy for fungi, fungal culture, and histopathology. So these are, in 2018, these were de rigueur required by countries, and the ADL is essentially for low middle-income countries. The following year, we added histoplasma antigen, and given that Sri Lanka is endemic for histoplasmosis, this is an important test for you as well, particularly for immunocompromised patients and HIV patients. And then 2 years after that, in 2021, we added Aspergillus antigen, Aspergillus IgG for chronic pulmonary aspergillosis and pneumocystis PCR. So these are the tests that should be available really to all low middle income countries. And this was their recommendation, active recommendation of Aspergillus IgG testing as a disease-specific test for clinical labs to aid in the diagnosis of chronic pulmonary aspergillosis. So there are different tests. I've mentioned the Immunicat test, which is the one that we tend to use in the UK, which is a semi-automated platform. There are 3 ELISAs. In fact, there are more, but there are certainly these 3. Bio-Rad have a good ELISA. So does Cerion Virion. Its performance is not quite so good. And then the Bordier assay is also pretty good. But you can see that none of these tests are 100% sensitive for the disease. and the lack of specificity reflects the fact that you can get an Aspergillus IgE from something other than chronic pulmonary aspergillosis. You can have Aspergillus bronchitis, you can have ABPA, you can have recovered from invasive aspergillosis. So there are other reasons for a positive Aspergillus IgG, and that's why one of the reasons why the specificity is not 100%. So then there's this lateral flow assay that was introduced about 3.5, 4 years ago. And these are some examples. And in the UK, this really performed pretty well using blood donors as the group looking for specificity. And that was actually, it had a better performance than Immunicap, in fact. So many labs in Britain probably should be running this alongside Immunicap if they suspect chronic pulmonary aspergillosis. In Indonesia, our work, it was not quite as specific or sensitive, and that reflects the inability in some patients to make a complete diagnosis. And because they didn't do CT scans in this study, there was still a lack of gene expert testing for some of the TB patients and so on. So that's one of the limitations of trying to do diagnostic studies. However, this is a good test. It takes 30 minutes and it costs about €4. So this is a good and helpful test. And when they looked at it in Chandigarh, you can see that they found it to have about an 87% sensitivity and a specificity which varied depending on the control group. So this is a very useful, simple, inexpensive assay. Now, there are many, many different aspergilli that cause disease. Here's a lovely selection from Marian Klitsch, who studied these in detail. Fumigatus is the most common, but we do see CPA caused by flavus and probably by Niger as well. And if you have Niger, you can have oxalic acid or oxalate crystals produced alongside, and some patients present with renal dysfunction, and in tissue you can see these crystals sometimes. But getting a positive culture out of patients is not always easy. So in the UK until fairly recently, the standard approach was to take a sputum sample and culture 1 microliter or maybe 10 microliters, and that's what you call conventional culture. And you can see that your yield from these patients is around 15–18% on a given sample. This is both ABPA and CPA, it's both of those combined. If you do a high volume culture, so you plate the whole sample, or at least a mil of sample, and you don't pre-process it with sputazole or dithriotol, you get a higher yield. It's around a 50% yield. And you can get also a higher yield with PCR. And if you combine PCR and high volume culture, you get up to about 75%. It might have been higher if these patients had all been untreated, but in fact, some of them were on antifungal therapy when the samples were taken. So I just want to make one other significant point about the management of these patients. This was a patient who came for a routine hysterectomy. She was asymptomatic, but the chest X-ray was abnormal, and they diagnosed fibrocystic sarcoidosis. So she then saw a young chest physician who thought she needed some steroids, which, despite her not being symptomatic, and fairly quickly thereafter, she had progressive chest X-ray findings with new cavity formation, pleural thickening, and small aspergilloma in that area. And a little bit after that, you can see this quite large aspergilloma. And so this is the danger of giving steroids to patients who have a chest disease which might benefit from steroids without giving antifungal therapy if they are at risk of CPA. And we know that if you treat patients with CPA and steroids, you increase mortality by 250%. It's a big, big increase in mortality. So be very careful of steroids without appropriate antifungal therapy. So we normally treat with itraconazole, voriconazole, or posaconazole tablets these days. The data is not very strong for posaconazole, and there's only a little bit of data for isavuconazole as well. We typically use 400 milligrams a day for itraconazole. If you use less than that, they're usually subtherapeutic, and it increases your risk of resistance. And then we adjust with therapeutic monitoring, and some patients only need 300 milligrams a day, and some need 500 or 600 milligrams a day. With voriconazole, because we treat a lot of elderly people, and some people get a little confused with voriconazole when it's first started, we tend to use a lower dose in small people and older people, 150 twice a day. But younger people may need up to 250 or even 300 milligrams twice a day. And again, we use TDM for that. And it's obviously really important to check for antifungal drug interactions. And we have a database online which you can search very easily, or you can put it on your phone. But you can see that with the severe interactions, itraconazole, voriconazole have a lot of severe interactions which need to be looked for and addressed. And so phone prescribing is tricky in these patients. So you start the patient on antifungal therapy. How long should you give treatment for? And this was addressed by a nice RCT, which Inderpal Sigal and colleagues in Chandigarh did, and which published late 2022. And what you can see is that if you treat for 12 months, the overall outcome goes up from 72% to 88%. So longer treatment is better for these patients. And if you also look at time to relapse, or patients relapsing after you stop therapy, if you've given longer treatment, there is less relapse, or at least it's delayed for longer. So probably 12 months of therapy is appropriate for these patients, and maybe longer, and we often treat patients for long periods of time. The other point to make is if you want to take the patient to surgery, we did a retrospective review of our about 60 patients who went to surgery and the timing of antifungal therapy. And if they have antifungal therapy before surgery, there is a substantially lower relapse rate than if they have antifungal therapy only during surgery or after surgery. So we would prepare a patient for a surgical resection with antifungal therapy for 3-4 months before surgery, and give them perioperative treatment. It may not be necessary if they then have a clean resection to give them any therapy after surgery. But if there's any concern about spillage into the pleural cavity, then that would be appropriate. And the last point I want to make is that it is the problem with patients who get worse on therapy. So this was a lady from Malawi who happened to have HIV as well, but she was well controlled. She had this is a long time ago, so we were using precipitin titers, high, strongly positive precipitin titers, 2 different areas of CPA, and we elected not to do what would be required as a pneumonectomy, so she was treated with itraconazole. That was in February 2005. 2 years later, with well-controlled HIV, she has new hemoptysis. Her antibody level has gone up, which is often a clue to failing disease or relapse disease. And you can see that her scan shows that the cavity near the hilum has substantially increased in size. And we grew from her sputum a resistant fumigatus, in this case resistant itraconazole, posaconazole, but not voriconazole. So she was switched to voriconazole, which we were lucky because many of these strains are not susceptible to that, and she responded to that. So in conclusion, itraconazole remains the initial treatment for CPA, but voriconazole is a good second choice, and there is an argument for using voriconazole because probably there's less chance of resistance associated with it. Azole resistance does occur on therapy, and it's relatively frequent. Patients who can't tolerate azoles or develop resistance may respond to IV micafungin or amphotericin B. Gamma interferon production is poor in many patients and may be helpful, and relapse after surgical resection is common but reduced if you give antifungal therapy before or after surgery. So this website, which many of you will know, has a large number of videos available to show you the different lab techniques, for example, interpretation of radiology and information about the disease. It's also got all the guidelines. So every guideline that's published is available on here. a link to the drug interaction website. And also, for those of you in the lab, you can go into the diagnostic section and you can click straight through to the tests that are available commercially for across all of the fungal, all the tests you might want to consider in the lab. With that, I will stop and thank you very much for your attention.